This will be your lesson 2 class, your electrolytes. So during the discussion, if there are questions, please try to answer. You could open your mic or you could try answering using the chat box. So let's start. Now, electrolytes class are basically ions capable of carrying electrical charges. So let's have a review. Now, as mentioned, ions are capable of carrying electrical charges, so which are either positive or negative. So pwede silang cation, pwede silang anion. Now, fluids would always contain balance of electrical charges. Meaning, class, yung mga body fluids natin, specifically the plasma. The plasma is the liquid portion of your unclotted blood. So unclotted blood, yan yung nagfo-flow sa blood natin. Kasi syempre, common sense, hindi naman pwedeng may clotted blood ka inside our body. That could cause a type of thrombosis and pwedeng magkaroon ng cessation ng blood, heart attack, and so on. So in our plasma class, there has to be a balance of positive and negative ions. Hindi pwedeng mas madami yung positive, hindi pwedeng mas madami yung negative. Now, this balance class is what we call electroneutrality. Electroneutrality means that there is an equal number of cations and anions. So, very important yan class, na balance dapat yan sa body natin. Now, there are different factors affecting dissociation of solutes. We have the chemical composition of a compound, and a concentration of other charged particles in the medium. Now, when you say dissociation of solutes class, this is the separation of your solid particles, such as your ions, from the solution or your plasma. So it could be related to the chemical composition of that ion. So, di ba, mga ions yun, they have different composition or their concentration, yung dami nila, the amount present in the medium. Now, let's talk about the functions of your electrolyte. Now, functions of electrolyte is that they are responsible for volume and osmotic regulation, myocardial rhythm and contractility, specifically your potassium. Potassium class is very important for your heartbeat. Heartbeat, the speed and slowness of your heartbeat, as well as muscle contraction. Now, they also serve as cofactors in enzyme activation. If you still remember, di ba, they are the inorganic cofactors. They are the inorganic cofactors in your enzyme activation, yung calcium, yung magnesium. Now, regulation of ATPase pump. Your ATPase pump class is responsible for cellular energy ng mga cells. Then we also have your neuromuscular excitability. This is also related to potassium. Production and use of ATP from glucose. Maintenance of acid-base balance, specifically the electrolyte bicarbonate. And also responsible for DNA replication and messenger RNA translation. Now let's tackle the first type of electrolyte class, the one of the most important, your sodium. Now your sodium class is also known as your natrium. Now this is the major extracellular cation. When you say extracellular, from the word extra, outside, then we have your cellular, outside the cell. Since this is a cation, this is a positive ion. So when you write sodium, Na+. So this is a positive ion, the major positive ion found outside the cell. Now, it is the principal osmotic particle outside the cell. Now, whenever you would hear the word osmotic, this is related to osmolality. Ang ibig sabihin ng osmolality class, this refers to the amount of solutes present in a solution. Para mas maintindihan nyo, sa body natin class, yung solute sa body natin, siya yung pinaka-major contributor. Meaning, siya yung pinakamadaming ion or siya yung pinakamadaming solute sa body natin. At ang solution dito is the plasma. In other words, class, your sodium is the major ion found in our blood. Ganun siya. Now, the plasma concentration greatly depends on water intake and water excretion. So, yung dami daw ng sodium class would depend or vary depending on the water intake of a person and its excretion. Now, reference values class found in the plasma and blood is 135 to 145 millimoles per liter. Now, mostly used unit for sodium class is your MEQ per liter, which is the conventional unit, while the millimole per liter is the SI unit. But in laboratories class, pag nag-work na kayo and even your internship, mas ginagamit pa rin ng international standard or standard international unit yung SI, which is the millimole. But in some laboratories in other countries, nag-MEQ sila. Now, conversion factor class, please take note for your sodium, your potassium, and your chloride is always 1. So, kung gusto mo i-convert yung MEQ to SI, same lang sila. There's no change. The conversion factor is 1. So, kung 135 to 145 MEQ siya, pag kinonvert mo siya sa SI na millimole, 135 to 145 pa rin siya. Now, the CSF sodium. So, sodium is also found in other body fluids such as your CSF. The value is 136 to 150 millimole per liter. Now, there's a threshold critical level. Threshold critical level, pag sinabi mo, this is the level wherein it would be critical or dangerous for a person. So, kapag ang sodium ng tao sa plasma niya is 160 millimole per liter, this is a sign that the patient has increased sodium known as your hypernatremia. But if the sodium naman class is around 120 millimole per liter, it means that the patient is suffering from hyponatremia. Now, abnormalities are confirmed through the measurement of serum sodium. Follow-up is usually done by urinalysis. Now, what are the functions of your sodium? So, as mentioned, one of those is your osmotic activity of the extracellular fluid. So, yung pag-maintain ng ECF class, isa yung sa pinaka-main function niya. Involves pulling water. Then we have your blood volume regulation, usually very important for controlling blood pressure. Then we also have your neuromuscular excitability, which is also done by potassium. So dalawa sila ni potassium class. Sodium and potassium would control neuromuscular excitability. Now, how is sodium regulated in the body? Now, the main controller of sodium in our body class is usually diet, yung kinakain natin. If there is too high sodium in the blood, you need to avoid salty food or those food rich in salt. Kaya nga class, whenever you would eat junk foods are high in salt or sodium. Kapag kumain ka ng junk food class, what happens is that there would be increased water retention. Kaya nga yung isa niyang function, 'di ba? Water pooling. It retains water in our body. Now when there is too much or there is increased water retention in our body, usually ang mararamdaman mo diyan is that you would feel bloated. So kung kumain ka ng sangkatutak na chichirya or junk foods after eating that, you would feel bloated due to the increased water retention. Now, another contributor for sodium regulation class is your kidney, your RAAS or your renin-angiotensin aldosterone system, and your ANF. ANF stands for the atrial natriuretic factor. Now, the atrial natriuretic factor class is produced by the atrial myocardium of the heart, which promotes natriuresis. Natriuresis class, please take note, refers to the urinary excretion of sodium kapag there would be excessive loss of sodium in the urine, vasodilation and relaxation of the smooth muscle. So let me repeat class ang purpose ng ANF nyo is that it would promote natriuresis, vasodilation, and relaxation of the smooth muscle. The most important function of your ANF class is natriuresis, wherein there would be urinary excretion of sodium and would lead sometimes to excessive loss of sodium in the urine. So kung mataas ang ANF mo class, there would be increased urinary sodium excretion. And when there is increased urinary sodium excretion, this would lead to decreased sodium in the plasma. So dapat ang level ng ANF nyo is normal lang because too much of it could cause increased urinary sodium excretion leading to decreased sodium in the blood. Now, what are the hormones affecting sodium level? We have your aldosterone, responsible for the absorption of sodium. The absorption of the DCT, the distal convoluted tubule, leading to retention of sodium and potassium excretion. So si aldosterone class allows the absorption of sodium. Reabsorption would occur in the distal convoluted tubule ng kidneys nyo. Then you have your ANF. This is also a antihypertensive agent. Endogenous class because it is naturally produced by the myocardium, blocks aldosterone and renin secretion, inhibits angiotensin 2 and vasopressin, or also known as your antidiuretic hormone. Angiotensin 2 class stimulates the production of aldosterone, causes natriuresis, prevents retention of sodium. Now, what are the clinical significance of your sodium? So there are two classes here, hypernatremia and hyponatremia. Let's start with hypernatremia. Hypernatremia class would occur if the sodium levels are greater than 145. But the level of 145 is still not considered critical. Di ba naalala nyo kanina, kailangan dapat nasa 160 siya to be considered critical. Then perspiration and breathing class, 1 liter water loss per day in adults. So if you undergo perspiration class and even by breathing in a single day, you would lose 1 liter. Then thirst class is the major defense against hyperosmolality and hypernatremia. So di ba kung ang body natin is detecting that it has too many solutes. Pag madaming solutes class, madaming mga solid particles sa blood natin. What happens is that the body would trigger a mechanism wherein you would become thirsty. Mauhaw ka. And by drinking your water class, you would be able to dilute your plasma. Therefore, kapag dilute siya, maglo-lower yung osmolality. Bababa rin yung pagiging hypernatremia niya. Now, the serum level of 150 to 160 MEq per liter would indicate a moderate deficit of water. Greater than 165 MEq per liter would indicate a severe water deficit. So let's say class 3 araw ka nang hindi umiinom ng tubig, it is expected if for let's say for 3 days you haven't drank any type of water, it is expected class that you would have an increased sodium level. So and they use this levels class to indicate yung pagiging hydrated level, hydration level ng body mo. Then we have your chronic hypernatremia. This is a long-term increased sodium, indicative of hypothalamic disease. So there's a problem with your hypothalamus class if there is a chronic hypernatremia. Now take note of the two possible major causes of hypernatremia: excessive water loss and increased intake or retention. Ulitin ko class, itong dalawa na to, these are the two major causes of hypernatremia. And under these two major causes, there are different diseases. Let's tackle them one by one. The first one, excess water loss. Under excess water loss, we have your diabetes insipidus, renal tubular disorder, prolonged diarrhea, profuse sweating, severe burns, vomiting, fever, and hyperventilation. Now, kapag meron kang diabetes insipidus class, if you have diabetes insipidus, meron kang tinatawag na condition known as your polyuria. Frequent urination, di ba? Usually greater than 2 liters. So, ganun kadami per day class ang iniihi ng person. Instead of the normal 1,200 to 1,500, you would be suffering from increased urination. Pag increase ang urination mo, of course, you would also suffer from decreased hydration, causing your solutes to increase. Dadami yung solutes mo, dadami yung sodium mo, leading to hypernatremia. Then we also have your renal tubular disorder. Kapag may renal tubular disorder ka, naalala nyo, di ba, ang kidneys nyo, they would reabsorb. They would reabsorb sodium. They would also excrete it via the urine. Ngayon, kapag may problema ka, if you have a problem with your kidneys will not be able to reabsorb, your kidneys will not be able to excrete sodium. And when that happens, class, sodium would remain in the plasma at a maximum level, mataas na level, leading to hypernatremia. And itong prolonged diarrhea, profuse sweating, syempre pag nagda-diarrhea ka, class, you tend to be dehydrated. So kapag dehydrated ka, of course, tataas din yung mga solutes mo, yung mga ions mo, leading to hypernatremia. Same with sweating, dehydrated ka din. Same with severe burns, vomiting, fever, and yun. So you would tend to be dehydrated. Another major cause of hypernatremia is increased intake or retention, seen in hyperaldosteronism, Ircon's disease, sodium bicarbonate infusion, increased oral or IV intake, and ingestion of seawater. That's why, class, if you are stuck at the sea, let's say na lumubog yung barko, please do not drink seawater because instead of quenching your thirst, mas lalo ka lang mauuhaw kasi dadami yung solute sa body mo. Now, the major causes of hypernatremia, class, please take note, is excess water loss, gain of sodium or both, and decreased water intake and increased intake or retention. Let's go to hyponatremia, class. So, hyponatremia is less than 135 millimoles per liter of sodium. Diba, ang critical is less than 120. So, this is the most common electrolyte disorder. Now, if sodium is greater than 20 millimole per day and there is more or less sodium in water, it would result to hyponatremia. So, pag mas madami daw yung loss ng sodium and water, class, mag-hyponatremia ka. A common cause of this is renal failure, wherein the kidneys ultimately fail to concentrate the urine. Now, glucose and mannitol, class, please take note, would induce diffusion of water from the cells to the ECF, thus diluting its electrolyte. So, itong glucose and mannitol, class, ang gagawin niya, kunwari ito yung cell. Inside the cell, class, you would find water. Now, if due to too much glucose and mannitol, what happens is that your water would exit. Pupunta siya ngayon sa extracellular fluid or the plasma. Now, because of it entering the plasma or the extracellular fluid, ang mangyayari ngayon is that this would cause a dilution. Mababawasan, dadami yung fluid, mababawasan yung anions, leading to hyponatremia. Now, glucose is osmotically active, so it will induce diffusion of water from the intracellular fluid to the ECM. Accumulation of these two is well-known cause of hyponatremia. Now, sodium disorders, hyponatremia, class, potassium deficiency causes loss of sodium. Potassium and sodium, class, have inverse relationship. Kaya lagi in your laboratory, if you see a result wherein the sodium is high, most likely, class, your potassium is low. Ganyan lagi yan. Usually, inverse talaga sila. They have an inverse relationship. Deficiency of potassium equals great loss of sodium. If there's low potassium, the tubules will conserve or reabsorb potassium. Then there would be low sodium. In return, since it will be excreted in exchange of the reabsorbed sodium. So ito, class, itong last statement na to. If there is low potassium, kung mababa daw yung potassium, ang gagawin ng kidneys nyo is that it would conserve or reabsorb potassium. And because of that, then it would lead to a low sodium class. Kasi nga, ini-excrete niya yung sodium so that it could reabsorb potassium. Ulitin ko ha, the reason why you have low sodium, class in cases wherein there is high potassium is because the sodium is being excreted so that the potassium could be reabsorbed. Appearance of symptoms, class, would occur at a serum level of 125 to 130 millimole per liter. Then serum sodium level of less than 125 millimole could lead to neurocytogenesis psychiatric symptoms. So, maapektuhan na yung utak nyo, class. And coma is the worst case. There are the major causes of hyponatremia, class. Increased sodium loss, usually due to decreased absorption. Increased water retention due to a diluted sodium. Water imbalance to determine the cause of hyponatremia and hypernatremia. Sodium, potassium, and osmolality of urine are also determined. So remember the three major causes: increased sodium loss, increased water retention, and water imbalance. So ito. Under increased sodium loss, class, we have the use of diuretics. 'Di ba ang diuretics nyo, class, they would cause frequent urination as well. And because of that frequent urination, sasama din yung sodium nyo. And even the use of saline infusion. Then we also have your increased water retention seen in renal failure, nephrotic syndrome, aldosterone deficiency, cancer, SIADH, or the syndrome of inappropriate ADH secretion. Now, sa SIADH, class, there is increased retention of water in the collecting ducts. So, mare-retain lang yung water sa collecting ducts ng kidneys nyo, class. And because of that, dinidilute niya yung sodium. Then you also have your hepatic cirrhosis, primary polydipsia, CNS abnormalities, and mycedema. Now, for the renal failure, class, damage or impaired kidney leads to decreased reabsorption of sodium. Then mycedema, class, is due to severe hypothyroidism. Then there's what we call a pseudo-hyponatremia, from the prefix pseudo, meaning false. Hindi talaga siya totoo, or it's not a true case of low sodium. This is just a false. Pag sinabing false, parang pretend lang siya, class. And this is usually caused by a problem with your sample or with the machine. Now, this is caused by a systemic error in measurement. Kaya nga ang pseudohyponatremia nyo, class, your pseudohyponatremia is not clinically associated with any condition. Now, the most common cause of pseudohyponatremia, class, is in vitro hemolysis. When you say in vitro, class, outside the body. Usually, ito yung nangyayari kapag nag-centrifuge ka. So, the hemolysis of RBC, class, results to falsely low sodium level, while the levels of potassium would falsely elevate. So, bababa yung sodium nyo, class, in a hemolyzed sample. At the same time, tataas naman si potassium. The reason is because your potassium are found inside the RBC. So, kapag nag-lyse yung RBC, your potassium would be liberated. Pupunta siya sa plasma, causing falsely elevated potassium. Thus, with in vitro hemolysis, there is falsely decreased sodium and falsely increased potassium. So, pakitandaan nito, class, in vitro hemolysis, the effects are falsely decreased sodium, falsely increased potassium. Now, what are the sodium assays, class? So, there are 4 assays done. We have your FEP. FEP stands for flame emission photometry. Your ISE refers to ion selective electrode. Now, the commonly used electrode, so sa ion selective electrode, kaya siya selective because it uses a selective electrode for each ion. Meaning, class, meron siyang specific electrode for the type of ion being tested. Sa ISE ng sodium nyo, for the ISE assay in sodium, this is the commonly used method. The electrode used here is the glass electrode. Then we also have your AAS, your atomic absorption spectrometry, or in some books, spectrophotometry. Then we have your colorimetric method, the Albanese lane assay. So ito yung gagawin nyo sa laboratory, class, itong colorimetric method. The sodium assay is your Albanese lane. wherein you would use sodium from the sample plus zinc uranyl acetate from the reagent. This would lead to a conjugation of forming a sodium uranyl precipitate. Now, the sodium uranyl precipitate with water would now form a yellow end color. So, the more yellowish it is, class, the more sodium present. Mas brighter yung color, mas more ions present. So, that's your colorimetric Albany-Slate method. Now let's go to the second important electrolyte, your potassium. Now your potassium uh, is the opposite of your sodium. So kung si sodium is known as your natrium, your potassium is known as your kalium. Now si sodium nyo is extracellular cation. Si potassium nyo naman is the major intracellular cation. Intracellular meaning inside the cell. So potassium is majorly found inside the cell. Majority of the potassium in the body is found within the cell. 90% of potassium found within the cell's class are free and exchangeable. Pag sinabi mong exchangeable class, it can swap position. Kaya niyang makipag-swap, meaning kaya niyang mag-enter, kaya niyang mag-exit ng cell. Meaning class, if the sodium on the extracellular fluid increases in level, it will go inside the cell and in exchange potassium goes out. So ulitin ko class, kapag daw mataas ang sodium nyo, it can enter the cell causing your potassium to go outside of the cell or to exit the cell. Now, chloride shift also works along with sodium. So, later explain ko kung ano yung chloride shift na yan sa chloride. Now, only 2% of the body's total potassium circulates in plasma. So, 90% class are found inside the cells, while 2% would only circulate in plasma. 90% of potassium in the body is found in the ICF, inside the cell. 2% is found in the bone or the brain tissue. RBC potassium concentration class is 105 millimole per liter. So, ganun siya kadami class. Ganun siya kadami inside the cell, 105 millimole per liter. This is 23 times higher class than its concentration in the plasma. Kaya pag tiningnan nyo sa plasma, ang reference value ng potassium nyo in the plasma is around 3.5 to 5.2 millimole per liter. Very far from the concentration found inside the cell. Filtered at the glomeruli and absorbed at the proximal convoluted tubule. Kung si sodium nyo sa DCT, si potassium nyo naman sa PCT. Mostly reabsorbed by active and passive mechanism in the PCT. 70 to 80% of potassium is absorbed in the proximal convoluted tubule. Then we have your ascending limb of the loop of Henle's loop or the loop of Henle class. Potassium is reabsorbed with sodium and calcium. So sa ascending limb of the loop of Henle class, potassium, sodium, and calcium are reabsorbed. This is done with potassium, sodium, and chloride co-transporters which participate in the reabsorption of this electrolyte. Reference value in the plasma class of your potassium is 3.5 to 5.2. Now, critical level class, if your potassium is around 6.5 millimole per liter and above, you have the condition known as your hyperkalemia. If your potassium is 2.5 millimole per liter and below, you have the condition hypokalemia. Now, what are the functions of your potassium? Responsible class for heart contraction. So, just to share you a story, merong case dati, a known doctor suffered from depression. The doctor suffered from depression. Since doctors are very knowledgeable, what he did, class, because of his depression, he was at the point of being suicidal. So what he did, he bought a solution of potassium. Since doctor siya, marunong siya mag-perform ng phlebotomy. So bumili siya ng solution ng potassium, ginawa niya ng aliquot, then dinilyot niya ng water, in-inject niya sa sarili niya. He died of heart attack. So that's one way he died of ano. So too much potassium class, very high amounts of potassium could lead to a heart attack. That's why ang potassium one of its function is heart contraction. The neuromuscular excitability, regulation of ICF volume and hydrogen ion concentration. Now, potassium regulation is regulated by kidneys. So as mentioned, di ba, reabsorb siya sa PCT for the complete reabsorption and active secretion in the distal tubule. Then it is also regulated by the gut, specifically the intestines. So potassium secretion controlled by the gastric juice, reabsorption, small intestine, secretion via the colon and the rectum. Now, what are the major mechanism of diminished renal potassium excretion? So, may mga cases, class, wherein potassium has a decreased excretion by the kidneys. And there are three mechanisms why this happens. Bakit nangyayari yung decreased potassium excretion by the kidneys? Number one mechanism is reduced aldosterone or aldosterone responsiveness. So kung mababa ang aldosterone mo or you have a defective aldosterone, you could have decreased potassium excretion. Renal failure. So kung may problem yung kidney mo, it's not able to properly excrete potassium. Then reduce distal delivery of sodium. So again nga, di ba, inverse ang relationship nila. So kung mababa ang sodium mo, mataas ang potassium mo. Mataas ang potassium mo because it's no longer, it's not being excreted, class. So that's what happens. High levels of potassium in the blood can directly stimulate the production of aldosterone by the adrenal cortex. Once potassium levels get high, it would automatically send a signal in the adrenal cortex to produce aldosterone. And in return, it will promote excretion of potassium and absorption of sodium. So to explain this further, class, kapag ang body natin, when our body detects high levels of potassium, it would cause the production of aldosterone. Ngayon, ang gagawin ni aldosterone nyo, class, aldosterone, class, will now promote the excretion of potassium and the absorption of sodium. Pero as mentioned here, kapag reduce ang aldosterone mo or hindi nakaka-respond, let's say, walang ma-produce, so mataas yung potassium mo, let's say you have a high potassium in your body, the body sends a signal to the adrenal cortex to produce aldosterone. But sadly, there's a problem. May problema sa adrenal cortex mo. When you have a problem with your adrenal cortex, it will not be able to produce aldosterone. And when that happens, class, it cannot promote the excretion of potassium. Hindi makapag-excrete yung body natin ng potassium at hindi makapag-absorb ng sodium. So that's the relationship of aldosterone. So ulitin ko, class, kapag mataas ang potassium mo, magpuproduce ng aldosterone. Si aldosterone would promote the excretion of potassium and absorption of sodium. If your adrenal cortex has a problem, aldosterone cannot be produced or it could have a defective aldosterone, leading to the absence of the excretion of potassium. Now let's talk about its clinical significance ng potassium nyo. So we have your hyperkalemia. Hyperkalemia, class, would be caused by reduced aldosterone or aldosterone responsiveness. We have your so-called hyporeninemic hypoaldosteronism. This is the most common cause of chronic hyperkalemia. So here you have your low renin, class, low aldosterone, leading to increased potassium. This is due to impaired excretion of potassium caused by chronic renal insufficiency. For those conditions associated with aldosterone deficiency, the most common cause is your hyporeninemic hypoaldosteronism. Most common cause of chronic hyperkalemia in non-dialysis patient. So if you're a non-dialysis patient, ang pinaka-major cause ng increase or prolonged increase ng potassium nyo is this so-called hyporeninemic hypoaldosteronism. Then another cause class is renal failure. Renal failure is wherein your kidneys are no longer able to excrete potassium. So there would be accumulation of potassium in the plasma. In renal failure, there is accumulation of potassium in the plasma due to reduced glomerular filtration rate. Pag sinabi mong glomerular filtration rate or your GFR, this is wherein your speed or the ability of the kidneys to excrete and reabsorb a substance. So kung mabagal ang pag-reabsorb or pag-excrete ng potassium nyo class, it would lead to accumulation ng potassium sa plasma mo. And when that happens, magkakaroon ka ng hyperkalemia. Aldosterone is also impaired as it promotes reabsorption of sodium, and as a result, greater potassium is excreted. Now, hyperkalemia affects the cardiac muscle. It decreases the resting membrane potential of the cell. Severe hyperkalemia can cause a lack of muscle excitability. 6 to 7 millimole per liter of potassium class may alter your electrocardiogram. Involves the movement of pumping of the heart. Now, if you have a potassium level of 10 millimole per liter, so ito yung sinasabi ko, you could have cardiac arrest. Above or equal to 10 millimole per liter is fatal, resulting to cardiac arrest. Acidosis and drugs on hyperkalemia class. So kapag meron kang acidosis, pag acidosis class, this refers to a low pH ng blood mo. Acidic yung blood mo class, you would have increased plasma potassium. So when your blood pH becomes acidic, there would be increased levels of potassium in the blood. This is because class the hydrogen ions would enter the RBC, and in exchange there will be movement of potassium going to the ECF. If naalala nyo, di ba class, for a solution or for a sample to be acidic, it needs to have more hydrogen ions. So kapag mas madaming hydrogen ions class, mas nagiging acidic siya. The more hydrogen ions present, the more acidic it becomes. So nangyayari dito sa acidosis, lumalabas yung umi-enter yung hydrogen ion sa RBC mo. And because of that, there would be movement of potassium going to the ECF. So lalabas ngayon yung yung potassium sa cells going to the plasma, leading to hyperkalemia. Then we have your therapeutic potassium administration. So this is the most common cause of hyperkalemia among hospitalized individuals. Potassium is usually given with the dextrose. So kaya nga yung mga nurses class and even the doctors, they need to know the speed, yung rate ng dextrose nyo. Di ba po na hospital na kayo, meron doon silang ina-adjust na iniikot-ikot. So they need to identify yung speed per hour, because if hindi nila makontrol yun, it could lead to hyperkalemia. Now, major causes of hyperkalemia would include decreased renal excretion. Sodium is absorbed by the kidney. As a response, there would be excretion of potassium. If there is decreased excretion, more will be reabsorbed going back to the blood. Then we have your extracellular shift, wherein from the ICF, pupunta siya sa ECF. Example is lysis. So from inside the cell class, potassium will go outside, will go and enter the plasma. Increase intake, administration of potassium through IV or oral drug, and use of immunosuppressive drugs. So immunosuppressants class will elevate the level of potassium because they suppress or reduce the excretion of potassium done by the kidney. So ito yung two major causes class, decreased renal excretion, extracellular shift. Under decreased renal excretion, we have your acute and chronic renal failure, severe dehydration, and Addison's disease. Then for the extracellular shift, we have your acidosis, muscle cell injury, chemotherapy, vigorous exercise, and intoxication. So kanina, di ba, as mentioned dito, kapag extracellular shift class, from the inside the cell, lalabas siya sa ECF or sa plasma. So ito yung mga conditions: acidosis, muscle cell chemotherapy, vigorous exercise, and intoxication. Now, there's also what we call pseudo-hyperkalemia. So pseudo-hyperkalemia is a false increase of potassium, usually caused by hemolyzed sample, increased platelets or thrombocytosis, prolonged tourniquet application, fist clenching, blood stored on ice, IV fluid, high blast count, and recentrifugation of serum separator tube. So whenever you would perform extraction for potassium class, dapat less than 1 minute yung tourniquet, and there should be no fist clenching. Sa ibang laboratories, they're not allowed to use tourniquet when collecting blood for potassium. Then after hyperkalemia, we have your hypokalemia class. Now under hypokalemia, we have your gastrointestinal loss, low reabsorption of potassium in the small intestine. So dito class, there's a problem with your small intestine, wherein the small intestine class is not able to reabsorb potassium. And because of that class, it would lead to a decreased potassium in the blood or in the plasma, leading to hypokalemia. Now, the major organ involved here is the kidney. Then we also have your renal loss, no to low reabsorption of kidney, in the PCT. Intracellular shift, diffusion of potassium back to the ICM. So from the plasma class, pupunta ngayon si potassium inside the cell. Example of this is wherein an individual undergoing insulin treatment. Insulin kasi class promotes the entry of potassium back into the cell. So may mga diabetic class na they would suffer from hypokalemia. So under gastrointestinal loss, we have the condition gastric suction and laxative abuse, intestinal tumor and malabsorption, cancer and radiotherapy, vomiting, and diarrhea. For the renal loss, we have your diuretics, hyperaldosteronism, Cushing syndrome, leukemia, Bartter syndrome, Geitelman syndrome, Liddle syndrome, and malignant hypertension. Itong Bartter syndrome na to class is a condition wherein your kidney has defective ability to reabsorb sodium. Then for the Cushing syndrome, this should be potassium. Potassium yan. Defective yung pag-absorb niya ng potassium. Then for the Cushing syndrome, characterized caused by elevated cortisol. Cortisol which promotes the reabsorption of potassium. Then, another one, hypokalemia class. So, mild hypokalemia is 3 to 3.4 millimole per liter. Normal value of 3.5 to 5.2. Conventional unit is MEQ per liter. Now, take note class that hypomagnesemia, pag mababa ang potassium nyo, if your magnesium is low, it would also lead to low potassium. Hypomagnesemia promotes greater loss of potassium in the urine, making the plasma potassium very low. Ammonium ions will be secreted to balance the level of potassium. Then we have your impaired renal function or renal loss. This is the most common cause of hypokalemia due to increased activity of aldosterone or other mineralocorticoids. Aldosterone promotes secretion of potassium. Other causes would include primary and secondary hypoaldosteronism. Increased aldosterone lead to low potassium. Extrarenal loss seen in diarrhea, where indirect potassium loss in the feces and stool, and vomiting. Hypokalemia affects the cardiac muscle. So, ang effect ng hypokalemia kapag mababa ang potassium nyo class, it would lead to decreased cell excitability by increasing the resting membrane potential, resulting in arrhythmia and paralysis. Then we also have your pseudo-hypokalemia. Leukocytosis can falsely decrease potassium level if the sample is left at room temperature. WBCs or active leukemic cells can consume potassium, promoting the influx of potassium into the RBC. So kung mataas ang WBC nyo class, excuse me, it would consume, yung WBCs present would consume the potassium, causing it to enter the RBC. Wait lang ah. Okay, let's continue. Now, potassium assay. So first we need to have specimen considerations class. So if you're going to use a hemolyzed sample, let's say ang potassium talaga ng patient is 4.2 millimole per liter. But because you use a hemolyzed sample, this would now cause it to increase by 0.5. So instead of 4.2, it would now become 4.7 millimole per liter. So that's a very high increase class, bothering yan. So as much as possible, do not use hemolyzed sample for your potassium. It causes an increase of 0.5 millimole per liter. Now, plasma levels are lower compared to serum levels. So that's why it's always important, class, to always use serum for your electrolytes. Excuse me again. Then, another consideration, class, is your muscular activity. So as much as possible, avoid contracting muscle. So there should be no fist clenching, and make sure that your patient did not run or did not do any strenuous activity prior to specimen collection kasi magkakos yan ng false positive, false increase. Then avoid prolonged contact of the serum and red cell. So as much as possible, once centrifugation is done, separate the serum from the RBC. Then prolong tourniquet application. So here are the different potassium assay. We have your FEP, flame emission photometry, flame emission photometry. Then we also have your valinomycin. So kung ISE, so kung sa sodium glass electrode, dito naman sa potassium, it uses a valinomycin membrane electrode. Then we have your AAS and the colorimetric method, Lockhead and Purcell. So kung sa sodium, ang colorimetric method is your Albanese lane. Sa potassium, it's known as your Lockhead and Purcell. So potassium assay is the Lockhead and Purcell, wherein potassium plus sodium would convert it into sodium potassium cobalt nitrate. The end color is blue. The reagent is sodium cobalt nitrate. So in your laboratory class, pag nag-test kayo, ang end color dapat should be blue for potassium. Sodium is yellow, blue naman for potassium. Reagent is sodium cobalt nitrate. Now, differential diagnosis for hyperkalemia. So let's say, as a medtech class, you're having trouble. You suddenly encountered, when you tested a patient for potassium, you notice a very high potassium level. So to double check this, you need to do the following. Rule out pseudohyperkalemia. Check if the sample is hemolyzed. Check if the patient underwent strenuous exercise. Check any possible error wherein you did not separate immediately the serum from the RBC. Then differentiate among the three major causes of hyperkalemia. So identify nyo ba? Is it because the patient has increased intake? When you say increased intake, did the patient, yung naka-admit na patient nyo, did you collect, let's say, to give you. So after that, na-identify mo na yung hyperkalemia. Is it because of increased intake, shifting of potassium into the ECF, yun nga yung wherein lalabas siya class, or there would be impaired excretion. So impaired excretion, try nyo i-check yung history ng patient if the patient is suffering from renal failure, may problem ba sa kidney. Then 24-hour urine potassium distinguishes increased intake. Then differential diagnosis for chronic hyperkalemia class is because of renal causes. Excuse me. So most of the time, kapag sobrang taas ng potassium ng body mo, this is usually a problem with the kidney, wherein there would be plasma renin activity, plasma aldosterone, urinary excretion of sodium and potassium. You could use random specimen or 24-hour urine. So kapag may mga chronic hyperkalemia ka, usually doctors would test for those. Yung renin activity, aldosterone, and urinary sodium, potassium. Now, measurement of urinary excretion of potassium. So, low urinary potassium excretion class. So, let's say you have a very low urine potassium. This could be caused by low intake, extrarenal loss of potassium, usually defective absorption in the GIT, intracellular shifting of potassium into the cell. Normal or increased urinary excretion, this is due to renal loss. So if there's renal loss, try to measure plasma renin activity and plasma aldosterone. Then for the ISE, both sodium and potassium applicable. Sa ISE class, there are two methods, the direct or the indirect method. Kapag direct method, from the word direct, you directly measure the serum and the plasma. If it's indirect method class, you need to dilute the sample using a buffer before running the tests. Then the sodium electrode uses a glass membrane electrode. For the potassium, as I mentioned, valinomycin membrane electrode. Now let's go to the third ion. Wait lang ulit. Okay, the third ion class is your chloride. Now, chloride is the major anion of the extracellular fluid. So, this is a negative ion class. So, partner sila, ECF. So, partner sila ng sodium. Sodium is your major ECF cation. Si chloride, major ECF anion. So pareho silang found in the plasma class. They are outside. Sodium and chloride are both found outside the cell. Now, sodium is the major cation of the ECF, while chloride is the chief counter anion of sodium in the ECF. So, siya yung opposite ni sodium. Chloride is usually a part of salts like sodium, potassium, and magnesium salt. Now, chloride class is excreted in the urine and sweat. Sample for chloride could use blood, urine, or sweat. So for testing chloride class, you could use blood, urine, or even pawis or your sweat. These orders of chloride are the same as sodium. When sodium is increased, chloride will also increase. Now, in the laboratory class, once you start working, the routine electrolytes that are tested are your sodium, your potassium, and your chloride. Now, most of the time, class, if your sodium is high, your potassium would be low, but your chloride would be high. So, ulitin ko klasa, the three commonly tested electrolytes in the lab are sodium, potassium, and chloride. Sodium and chloride class are always the same. Si potassium lang yung different or yung opposite. So, kung mataas si sodium, mataas din si chloride, but potassium would be low. That's the usual result that you would encounter when you test the three. Now, disorders of chloride are the same as sodium. When sodium is increased, chloride will also increase. Reference value is 98 to 107 millimole per liter. Functions of chloride would include maintaining osmolality, blood volume, and electroneutrality. Now, specimen consideration class. For marked hemolysis class, baliktad, di ba? Sa sodium, sa potassium, if there's an hemolysis, it would cause false increase values. Pero si chloride, falsely decrease values niya. So if you're going to use a hemolyzed sample, chloride would be falsely decrease. If you use a postprandial specimen, pag sinabi mong postprandial, after eating, So let's say kumain yung patient ng 7 a.m., tatapos siya kumain ng 7:30, kinunan mo ng kinunan mo ng dugo ng 7:35 a.m. That's an example of a postprandial sample. So postprandial sample is a sample taken after eating. Now, if you do that, the chloride result would be slightly lower. Now, chloride testing does not require fasting. Immediately after eating, the chloride in the intestines will be used to make hydrochloric acid, which is necessary for digestion of food. So the reason class why slightly lower ang chloride is because it is being consumed to make hydrochloric acid necessary for digestions. Now, conditions with high bicarbonate levels. So, if a patient is suffering from diseases that would lead to high bicarbonate levels class, it would produce a low chloride result. Now, these are the chloride assays used. We have your mercurymetric titration, known as your shales and shales, spectrophotometric method, colorimetric amperometric titration, and your IS. Now, in the laboratory class, usually use itong shales and shales. Shales and shales would use an indicator of diphenyl carbazone, and product is your mercuric chloride. Then there's also your white horn titration method, known using mercuric thiocyanate. It forms a reddish complex. Then meron ding ferric perchlorate. This is a colored complex. Color is dependent on the chromogen you would use. Then we have your colorimetric amperometric titration. Uses a Kotlov chloridometer used to measure the level of chloride in sweat in particular. Then we have your ISE. So sa ISE class uses an ion exchange membrane, either silver sulfide or silver chloride. So let's have a recap ha. Kapag sodium, glass. Kapag potassium, valinomycin. Kapag chloride, it would either use silver sulfide or silver chloride. So that's for your ISE, ion selective electrode. Clinical significance class. So kapag meron kang hyperchloremia, increase chloride. This is usually seen in renal tubular acidosis, diabetes insipidus, salicylate, salicylate intoxication, primary hyperparathyroidism, metabolic acidosis, prolonged diarrhea. Then for decreased chloride, hypochloremia, seen in prolonged vomiting, aldosterone deficiency, metabolic alkalosis, and salt-losing nephritis. Now let's talk about the three types of chloride in our body: the CSF, the urinary, and the sweat chloride. Now, CSF chloride class, take note, is higher than that of serum. So, mas mataas siya kaysa sa serum natin class or sa plasma. Proteins are very low in the CSF. Remember that proteins serve as anions. It is not normal for proteins to be found in the CSF. Remember class, ang CSF natin has a separate layer. Yung B, B, your blood-brain barrier. You know, your blood-brain barrier class prevents ions from entering the CSF. Uh, that is why proteins are very low in the CSF class. And if there is high amounts of protein in the CSF, there could be a possible infection such as meningitis. That's why expected to be low class in CSF. Chloride comes in to compensate to serve as anions. Reference value of chloride is CSF chloride is 115 to 132 millimole per liter. Low levels would indicate bacterial meningitis. Now we also have your urinary chloride. Greatly varies with chloride intake. Variable. If there's a low salt diet, there will be low or less chloride excreted in the urine. Reference value class is 110 to 250 millimole per day. Low levels are found in patients on low salt diet. Then we have your sweat chloride. So sa sweat chloride class is used in the diagnosis of cystic fibrosis. So sample is wet. Increased chloride in sweat is diagnostic of cystic fibrosis. In cystic fibrosis class, there is a problem with the chloride channel preventing reabsorption of chloride. Ang tatandaan nyo dito sa sweat chloride test na to, may yung test niya class, it would use the drug pilocarpine. Si pilocarpine class is a sweat-inducing drug. Let's go to the fourth electrolyte, calcium. Now, calcium class is the most abundant. Siya yung pinakamadami. Most abundant cation in the extracellular fluid. Sodium is the major cation, pinaka-importante class, pero hindi siya yung pinakamadami. The most abundant cation is calcium. 99% is found in bones, 1% is found in the blood and ECM. Absorption of calcium occurs in the duodenum. Maximal absorption is in the duodenum assisted by acidic pH. Acidic pH would lead to greater absorption in the duodenum. Reference value class, total calcium. So, dalawang calcium yan. The total calcium and the ionized calcium. For total calcium class, reference value for adults is 8.6 to 10, while for children, it would be 8.8 to 10.8. For ionized calcium, for adult, it would be 4.6 to 5.3. For children, 4.8 to 5.5. Calcium function class is your blood coagulation. Okay, factor 4. Very good. So, siya yung naalala nyo, di ba? Factor 4 siya. It's a very important in both intrinsic and extrinsic pathways. It allows the coagulation. Enzyme activity, di ba? It serves also your coenzyme, cofactors sa mga enzymes nyo. Excitability of skeletal and cardiac muscle. Maintenance of blood pressure. It tightens or narrows blood vessels. Calcium-rich diet decreases blood pressure. Then we also have your calcium regulation. So how is your calcium regulated? It usually involves three hormones class. Yung 1,25-dihydroxycholecalciferol, also known as your vitamin D3. Now, the activated form of vitamin D3 class is known as your calcitriol. So, ulitin ko ha, activated form of vitamin D3 is known as your calcitriol. Calcitriol class increases PTH and decreases phosphate, derived from successive hydroxylation in the liver and in the kidney. So, ang ginagawa ni calcitriol class, it increases the following: intestinal absorption of calcium in the GIT or gut, reabsorption in the kidney, and mobilization of calcium from the bones. Osteoclastic resorption in the bone increases calcium level. So kapag ang body natin class, very low ang vitamin D3, the following problems would occur. Magdi-decrease ang intestinal reabsorption, magdi-decrease ang reabsorption sa kidney, magdi-decrease ang release ng calcium from the bones. So it's very important that you have a normal vitamin D3 in our body. Then the second hormone is your parathyroid hormone or your PTH. Si parathyroid hormone class conserves calcium, increasing reabsorption in the kidneys, increases the calcium level secreted by the parathyroid gland when plasma ionized calcium is low. So when your body detects that the calcium level is low, your parathyroid gland would secrete PTH. PTH would increase the reabsorption ng calcium sa kidney. Activates the process of bone resorption, mobilizing bone calcium, suppresses urinary loss of calcium, stimulates the conversion of inactive vitamin D to active vitamin D3 in the kidney. And the last one is your calcitonin class. Calcitonin is produced by the C cells of the thyroid gland. Lower calcium level in the blood. Hypocalcemic hormone. Inhibits PTH and vitamin D3. Inhibits bone resorption, promotes urinary excretion of calcium. Now, what are the forms of calcium class? We have your ionized or the active calcium. This is usually free, not bound to protein. 50% of calcium. In the laboratory, again, class, most tests requested by doctors are the ionized calcium. The reason ba't siya ginagamit, class, because this is free. Hindi siya bound sa protein. And since hindi siya bound sa protein, class, there would be less interference. More accurate siya. That's why it's considered a specific marker for calcium disorder. So kapag nakita ng doktor that you have lower ionized calcium, most likely you have a problem related to that. Then we have your protein-bound calcium, which is 40% of calcium. And then we have your complex calcium with anions, usually complex with citrates class. This is 10% of calcium. So yan yung three forms. Usually, ang pinaka-tested is the ionized or the active calcium. Now, a lab consideration pala sa ionized calcium. In ionized calcium, you need to collect a sample anaerobically. Pag sinabi mong anaerobically, no exposure to air. Factors affecting calcium level. So the factors would include decrease in plasma protein concentration. Pag decrease ang plasma protein concentration nyo, decrease ang total calcium level nyo. Again, di ba nga, 40% are ionized. 50% are protein bound. So kung mababa ang proteins mo class, there would be less protein bound calcium. And kapag less ang protein-bound calcium mo, it would lead to decreased total calcium level. Then prolonged contact of serum with the clotted blood would also decrease calcium level. Recumbent posture, lying or resting position would decrease calcium. Venous occlusion. Venous occlusion class is basically how occur when your veins would collapse. Seen in traumatic venipuncture, which would lead to increased calcium. Acidification class. Low pH would cause calcium bonds to proteins to be free, leading to increased calcium in the blood. Increased urinary excretion. Increased excretion class decreases blood levels. Clinical significance class. So hypercalcemia would be seen in primary hyperparathyroidism, cancer, specifically lung and breast CA, acidosis, increased vitamin D, multiple myeloma, sarcoidosis, hyperthyroidism, milk alkali syndrome, hypocalcemia class seen in tetany, initiated by the fall of calcium levels, alkalosis, vitamin D deficiency, primary hypoparathyroidism, acute pancreatitis, hypomagnesemia, malabsorption syndrome, and renal tubular failure. Now, hypocalcemia class could be, there are two types, yung primary and secondary. So, primary hypocalcemia is usually caused by low parathyroid hormone. So, this is usually a problem. May problema ka dito sa parathyroid gland mo. Nothing will stimulate to produce calcium. So if you have low PTH, walang magkakos ng production ng calcium nyo. Something is wrong with the parathyroid gland. Impaired ang secretion ng PTH. While your secondary hypocalcemia is characterized by high PTH. Walang problema ngayon sa class sa parathyroid gland. The parathyroid gland here is normal. So ulitin natin na kapag primary hypocalcemia, there's a problem with the parathyroid. Pag secondary, there's nothing wrong or normal ang parathyroid gland nyo. This is usually caused by a consequence of low magnesium or phosphate level. the body is trying to compensate the level of calcium. Then we have your severe hypocalcemia, seen when the total calcium levels are less than 7.5 milligram per DL. Then there's also your false or your pseudo hypercalcemia, false increase ng calcium, seen in dehydration or hemoconcentration. Hemoconcentration class is wherein your sample or your plasma is too concentrated. Marami siyang solutes present. And one factor contributing this is the elevation of albumin. So kapag madaming albumin sa blood mo, you could have hemoconcentration. Calcium would bind with albumin, so there would be false elevation of total calcium. Ionized calcium, however, is normal. So sa hemoconcentration class, you would be expecting to see a falsely increased total Ca and a normal ionized Ca. So yan yung magiging result niyan. So do take note of that. Then we have your phosphorus. Exists as inorganic phosphate or as organic phosphate ester. Organic phosphate, uh, organic phosphate. So pag phosphorus class, lagi itong tinatawag siya na inorganic PO4 or inorganic phosphorus. Yan yung laging tinitest sa body natin. Inorganic phosphorus is part of blood, specifically in the extracellular fluid. Now, 85% class of phosphorus is found in the bone, 50%, 15% is found in the ECF in the form of inorganic PO4. So, hindi ka makakakita class, there is no organic PO4 being tested in the laboratory. Only inorganic PO4. Now, phosphorus is widespread in its distribution. It has an inverse relationship with calcium. So, remember that. So, kapag mataas ang calcium nyo class, it's expected that you would have a decrease in organic phosphorus. Now, phosphorus is absorbed in the jejunum, maximal absorption. Essential for the insulin-mediated entry of glucose into the cell. Particularly phosphate. Phosphate is involved in the phosphorylation of glucose along with the entry of phosphorus into the cell. Potassium will follow inside the cell, particularly in the red blood cell. Reference value class for adult is 2.7 to 4.5 milligram per DL in adults and 4.5 to 5.5 milligram per DL in children. Now, forms of phosphate class would include free or unbound form, 55%, considered as the active form, while those with complex with ions are 35%. Those that would exist in the serum, which are most inorganic forms, are those complex with ions. Then we have your protein bound, which is 10%. Factors affecting phosphate level class. So, PTH, parathyroid hormone. Decreased phosphate level by renal excretion promotes excretion of phosphorus, particularly phosphates, to the urine. Then we have your calcitonin, inhibits bone resorption of phosphate. So there would be decreased phosphate level in the blood. So si calcitonin nyo class inhibits the resorption of phosphate. Decrease yung phosphate sa blood. Then growth hormone class increases phosphate level by renal reabsorption. Practical consideration class. So whenever you would test for phosphate, fasting is required class. Protein-rich diet class would lead to decreased level of phosphorus. Then serum must be separated from the RBC. If red top is used instead of SST, separate immediately to avoid the results being affected. Assay for phosphorus class. So phosphorus is measured in terms of PO4 in terms of phosphate. Among the three forms, only inorganic phosphate in the serum can be measured in the laboratory. Laboratory results cannot be expressed in MEQ per liter. Blood collection is affected by circadian rhythm. So pag magko-collect ka ng for inorganic phosphate class, you need to take note of the circadian rhythm. So if you collect phosphate, blood for phosphate late in the morning to near noon, let's say 11 a.m. to 12 noon, levels of phosphorus will be elevated. Pag late in the evening, let's say 10 p.m., 11 p.m., phosphorus would be low. So the best time to take the sample is in the morning. Kaya nga siya fasting class. So ideal talaga dito is siguro 7 a.m. or 6 a.m. Fasting serum phosphate is controlled by the parathyroid gland. Affected by diet, patient should fast and sample should be collected early in the morning. Then the method used here is the Fish-Soborov method, which is a colorimetric method. Clinical significance class. So we have your hyperphosphatemia and hypophosphatemia. Hyperphosphatemia's class is seen in hypoparathyroidism, renal failure, if there is impaired kidney or renal disease. The excretion of phosphate is inhibited, leading to high level in the blood. Lymphoblastic leukemia and hypervitaminosis D would also lead to hyperphosphatemia. Then hypophosphatemia or decreased phosphate is seen in alcohol abuse, which is the most common cause. Sa alcohol abuse kasi class, if you are an alcoholic, pansin nyo ang mga chronic alcoholics class, hindi na sila kumakain. They tend to forget to eat. Iinom na lang sila. The reason for that class is because there is a decreased ability of your intestines to absorb nutrients. And one of those most affected nutrients is the ion or the electrolyte phosphorus. That's why alcohol abuse is most common. Most of the time kapag alcoholic ka, mababa ang phosphate mo. Then you would also have hypophosphatemia in primary hyperparathyroidism, vitaminosis D, mycedema, patients receiving carbohydrate hyperalimentation, and severe hypophosphatemia, which is seen if the phosphate in organic PO4 is less than 1 gram per DL or 0.3 millimole per liter. Now, let's go to another electrolyte, yung magnesium nyo class. Now, magnesium is the second abundant cation of the ICF. Most abundant class is potassium. So, for after potassium, si magnesium yung second abundant. This is the fourth abundant cation in the body, stored in the bones, muscles, and soft tissue, serum, and RBC. 53% of magnesium are found in bones, 46% are found in muscles and soft tissue, and 1% are found in the serum. Decreases uterine hyperactivity and increase uterine blood flow. Vasodilator for women during pregnancy. Loss of magnesium leads to decreased intracellular potassium shift. Reference value is 1.2 to 2.1 MEq per liter, and life-threatening levels of magnesium class is 5 millimole per liter. Functions class would include maintain structure of DNA, RNA, and ribosome, synthesis of carbohydrate, proteins, and lipids, neuromuscular transmission. It serves as a cofactor sa enzymes nyo and regulates movements of potassium across the myocardium. Now, there are three forms of magnesium. The free magnesium or the ionized magnesium. This is 55% of magnesium class. Majority of magnesium is in the form or is unbound to protein. While the remaining 30% and 15%, 30% are protein bound and 15% are complex with ion. Regulation class is via the parathyroid hormone. So pansin nyo, PTH class controls a lot of electrolytes, yung calcium, yung phosphorus, or yung phosphate, and even magnesium. So magnesium, there would be increased renal and intestinal reabsorption. Aldosterone and thyroxine increases the excretion of magnesium. So si PTH class increases the reabsorption. Si aldosterone and thyroxine excretion naman ng magnesium. Clinical significance class, hypermagnesemia is seen in diabetic coma, Addison disease, chronic renal failure, increased intake of antacids, enemas, and cathartic patient. Then we have your hypomagnesemia seen in acute renal failure, malnutrition, malabsorption, chronic alcoholism, and severe diarrhea. Again, the most common cause of low level magnesium is chronic alcoholism or alcohol intake. Assay class. So there are three colorimetric assays for magnesium: the Calgamite method, the Formazan-Dye method, the magnesium thymol blue method. So itong tatlo na to are all colorimetric. Then we have your atomic absorption spectrophotometry and the dye-lake method. Now, magnesium in relation to pH imbalance, magnesium diffuses out of the cell in exchange for chloride. So, ito yung tinatawag nilang chloride shift class. So, lalabas si magnesium in exchange for chloride. So, magnesium would go out, chloride would now enter. Buffering system of the blood is maintained by a reversible exchange process between sodium bicarbonate and chloride. So, di ba nga si sodium at si chloride class. So kapag papasok si sodium, lalabas si potassium. Dito naman class, si chloride naman at si magnesium. Si chloride class, si chloride papasok siya sa cell, si magnesium lalabas. So yun yung relationship. Yan yung tinatawag nilang chloride shift. Chloride would enter the cell and bicarbonate will exit, maintaining electron neutrality. Now, let's go to the last electrolyte class, yung bicarbonate. This is the second most abundant anion in the ECF. Most abundant is chloride. Accounts for 90% of total carbon dioxide at physiologic pH. Composition is undissociated sodium bicarbonate, carbonate, and carbamate. Function is that it buffers excess hydrogen ion, acid-base balance, buffering capacity. Major component of the buffering system in the blood, maintenance of high plasma bicarbonate concentration. Bicarbonate assay class ISE uses PCO2 electrode. Enzymatic, so take note class PCO2 electrode ang ginagamit for bicarbonate. So glass, valinomycin, then yung sa chloride class yung dalawa. Then for ISE naman ng bicarbonate is the PCO2 electrode. Enzymatic method would use a colored reaction involving two enzymes. It uses phosphoenol pyruvate carboxylase and dehydrogenase. Bicarbonate in relation to pH imbalance diffuses out of the cell in exchange for chloride. Buffering system of the blood is maintained by a reversible exchange process between bicarbonate and chloride. So sa chloride shift class, balik lang ako. Sorry. Instead of magnesium, dapat bicarbonate ito. So sila yung nag-shift kapag merong chloride shift. Okay. Now let's go to the last topic. Itong anion gap nyo. So anion gap class, take note, is the difference between unmeasured cations, sodium and potassium, and unmeasured anions, chloride and bicarbonate. A QC for the analyzer. So ginagamit siyang quality control to measure the level of electrolyte. Monitoring of recovery from patients suffering from diabetic ketoacidosis. Healthy individuals without diabetic ketoacidosis but abnormal anion gap is indicative of machine defect. So kung yung patient nyo is healthy, wala namang diabetic ketoacidosis, but abnormal yung anion gap class, it means that the machine is defective. Now, anion gap increased level is seen in uremia or renal failure due to greater retention of phosphate and sulfate. Ketoacidosis, poisoning of methanol, ethanol, glycol, or salicylate. Lactic acidosis, hypernatremia, and instrument error. So these are the two formulas. So may dalawang formula class for anion gap. We have your sodium minus the sum of chloride plus bicarbonate. So, i-add mo muna yung chloride sa bicarbonate bago mo isubtract sa sodium. Reference value is 8 to 16. The other formula, sodium plus potassium minus chloride plus bicarbonate. So, either formula is accepted class. If walang available na potassium, you could use the first formula. But if there's an available potassium, use the second formula. Iba-iba sila ng reference value. 8 to 16 millimole for the first formula, 10 to 20 millimole per liter for the second formula. So that ends the lesson 2 class electrolytes. These are the references used for this discussion. Thank you.